Okay, thank you very much, everybody, and welcome to the second session. So this is going to be a series of 4.5 minute, I'm going to be really strict, 4.5 minute elevator pitches. This is really so that you can have a good set of conversations over lunch with people, and you can find out a lot of the different things that are happening around. So we've got lots of good speakers. And so without further ado, our first speaker is going to be Maria Delgado-Ortet. And she's going to be talking about unraveling radiomics in ovarian cancer through image-guided interventions, from ultrasound-guided biopsies to 3D molds. Yeah. And hopefully your slides will appear. I'm reliably informed. Perfect.
Yeah. Okay. So hello, everyone, and thank you very much for attending, and thank you to the organization for the chance to let me give a talk on this. My name is Maria. I'm a PhD student at the Department of Radiology here at the University of Cambridge, and today I'm going to walk you through the work we've been doing in Addenbrooke's to understand heterogeneity in ovarian cancer. So ovarian cancer, every day in the UK, around 20 women are diagnosed with ovarian cancer, and 11 will eventually succumb to the disease. Even though most of the survival rates for tumors have improved over the last years, it's been steady for ovarian cancer since 1980s. And 70% of the diagnoses are high-grade serous ovarian cancer, which is not only the most common, but also the most lethal. And its aggressiveness has been linked to intratumor heterogeneity, but we don't have any tools in the standard of care to identify this heterogeneity or to understand it better. So this is where our motivation arises from. So is there any way we can put tools in the standard of care to understand it better? So first, let's have a look on how the standard of care looks like. When a patient is referred to the hospital with a suspicion of ovarian cancer, a contrast-enhanced CT of her abdomen and pelvis is taken, and then depending on how the disease looks, we may decide to take a histopathological proof to know what the diagnosis is. So we would go for ultrasound-guided biopsies, or we can go straight to surgery and then take the sample from here and then send it to pathology. However, no matter what the pathway is, pathology has no really a systematic way to approach spatial heterogeneity within a tumor. So what we need actually is a map. So what we propose from radiology is the use of radiomics maps using the preoperative images. And radiomics are features that can be extracted from CT images, and some of them really correlate with a heterogeneity within a tumor. So these maps will need to be integrated differently depending on which pathway we're going for. So first, I'm going to start with ultrasound-guided biopsies. The problem we have is that radiomic maps are extracted from CT images, but then we use ultrasound to guide the biopsies. So how can we fuse both images? And in that case, what we did is a work together with Canon Medical Research Europe. And what we can see in the screen is actually what the clinician sees while performing the biopsy. They see the real-time ultrasound on the right, and then on the left, they can see the CT superimposed with also the habitats. I'm not a clinician myself, but my colleagues tell me that from the right-hand side, you can see a needle going through and sampling what would be the red habitat in the image. Then now we're going to see what we propose for surgery. In that case, what we want to correlate is the images with the resected specimen during surgery. And for that, we propose the use of 3D molds. For that, the radiologist would first segment the image and would also mark which is the area that would make the mold the most stable. So the specimen doesn't collapse during sampling and stays in the position we intended to. Then the computational pipeline starts. And what we do is we extract the radiomic features, we create the radiomic habitats, and then we rotate the tumor and the habitats. So the orientation is the one that the radiologist desired. You can see how the tumor is printed on the right. The reason we print the tumor is because we will bring it together with the mold to surgery. So it takes the positioning of the actual specimen within the mold, because it's quite difficult as we don't have any anatomical references. And then once in pathology, the pathologist can use the mold to cut it exactly where they want. So each slice corresponds to one of our radiomic map slices. So my take-home messages today would be that we've actually developed pipelines for precision tissue sampling techniques in the clinic, so we can better understand the tumor heterogeneity. Both techniques can potentially be used for other organs. In fact, 3D printed molds have already been used for kidney. And ultrasound biopsies, we will potentially use them as well for kidney. This is also not useful only for research, but for the patients, but also there is a potential for the industry to explode all that. And finally, the patient recruitment has been very low. So we have unfortunately still not been really able to correlate all the imaging data with the tissue-derived data, which is radiogenomics, which is the end goal. But this should improve during the next years. So thank you very much for your attendance. I'm very happy to discuss it later.
Thank you, and thank you for your perfect timing. Our next speaker is Daniel Kreuter, and he's going to be talking about investigating bias in full blood count data.